Great. So we have started recording. Thank you, Kristen. I am just going to. Okay. Can everyone hear me? Just nod your head. It looks like you can. Great. Oops. A few more people are coming in. Give it to 5:01. Okay. Welcome, everyone, to the Green Mountain Care Board's Primary Care Advisory Group. We have a very robust agenda, and I am going to start tonight's meeting out with some introductions, and then we'll go through and have the Primary Care Advisory Group members introduce themselves, and we'll take a bit of attendance. And then we're going to hear from our own staff on a few updates from the Green Mountain Care Board side, then offer it up for the PCAG members to provide some updates. And then we have a guest tonight. We have Blue Cross Blue Shield of Vermont, and they're going to be reviewing their Vermont Blue Integrated Care Program. And then we'll wrap it up with a group discussion and public comment. So with that, I will first start out with some introductions. So I have a lot of new folks here from the, we have a couple of new PCAG, actually one PCAG member, but first I'm going to start with our own team. As members of the PCAG know, Christina McLaughlin, who staffed the PCAG for many years, moved on to a really great new opportunity serving some clients up at the state legislature. So I have the opportunity tonight to introduce another Green Mountain Care Board staff person who will be taking on the role of supporting this group. Her name is Jen DiPolito, and I'm going to turn it over to her to introduce herself.
Great. Thank you, Susan. Hi, I'm Jen DiPolito. I am a health policy analyst here at the board. I worked closely with Christina previously on our rate review process, so I support our rate review work here at the board, and I also support our ACO oversight work here at the board. And prior to my work here, I was working overseeing COVID response at the Vermont Department of Health on our contact tracing team and our operations prevention and response team. So I've worked with some providers across the state in that capacity, but I'm looking forward to working with all of you. So thank you for having me here.
Thank you so much. Thank you, Jen. And as you did, as members did with Christina, please feel free to reach out directly to Jen on any questions or follow-up items. She is here to support this group and has, as you can hear, a really great background to fill this role. So this is very exciting. Welcome, Jen. I'm going to move through a couple of other staff members, and then I will introduce some of the board members present tonight. So the next person I want to introduce is Kristen LaJeunesse, and I don't see her on camera. She can get on camera if she wants to. There she is. Thank you, Kristen. Kristen is fairly new to the Green Mountain Care Board. She is the executive assistant to the chair. And Kristen, would you mind just giving a quick hello and a little bit of background? You have a really impressive background too.
Thank you. I'm really pleased to be here tonight with you all. I've been with state government for about 8 years. I was previously with the Department of Buildings and General Services, working in their emergency management and safety and security. Before that, I was an Air Force officer spouse. And so we traveled the country for 21 years, traveled the world. And so I've got a lot of experience in public affairs and communication in the country and out in meeting other people in the world. So I'm really pleased to be here, and I'm excited to be in this position to help where I can.
Thank you so much, Kristen. We're so happy you're with us. And Kristen also will be supporting this group alongside Jen. So you can certainly reach out to her if you have questions as well. And then last but certainly not least, I'm going to ask Julia Bowles to introduce herself.
Yeah, thank you, Susan. My name's Julia Bowles. I'm a senior health policy analyst at the board. I've been with the board about almost a year and a half, and I think this is my second PCAG meeting, although I don't know that I introduced myself last time, so great to meet everyone. And I've been taking over some of the work that Christina used to do for us on covering the legislature, so you will hear from me again tonight. I'll turn it back to you, Susan.
Thank you, Julia. And Julia is, as she said, presenting tonight, and she may come in and out of these meetings as well. So I wanted to make sure she introduced herself. So now I will introduce our board. We actually have a couple of board members here tonight. Last time you met Owen Foster, who is our new board chair. And Owen, do you want to just give a quick hi for folks who weren't here before, maybe just an elevator update for folks?
Yeah, it looks like a lot of familiar faces. So I am Owen Foster. I'm the chair since October 1st, and this is my second PCAG meeting. And I appreciate you guys all being here. I know we have some good topics tonight, and nice to see the new folks.
Great, thank you, Chair Foster. And I don't see him on my screen, but I know he's here. Dave Merman, Dr. Merman. Maybe we lost you. I know he was coming off. Oh, there you are, a little field trip with his daughter. So go ahead, Dr. Merman.
In the car with my fifth grader. We just had finishing up a ski field trip with the middle school up to Stowe, Crossett Brook. I'm an emergency physician up at CVMC. Joined the board, started with the board on October 1st. Second PCAG meeting, I guess. And I'm just really happy to be part of the conversation. And thank you so much.
Great. Thank you, Dave. We're really happy to have you here tonight. And as in the past, we rotate through board members to attend these meetings. I do want to say out loud and as a reminder that this is an official committee of the board. So if all 5 board members wanted to attend, they could. So we do have minutes from this meeting, and we record this meeting as a reminder because it is that official committee of the board. So the next item, the next introduction is I want to introduce a new PCAG member, which is very exciting. We want to introduce Courtney, and I don't have your last name in front of me, so I think I'm going to turn it over to you, Courtney, and I'm so sorry on my notes I don't have your last name. So there you are. I thought it was Ledger. I'm like, I think it's Ledger, but I could have actually looked at my screen. So Courtney, welcome. And if you want to just introduce yourself to the group, that would be wonderful.
Yeah, thanks for having me, everyone. I'm Courtney Ledger, and I work now as a nurse practitioner in primary care at Richmond Family Medicine, and I've been there for about 8 years, and I'm excited to be part of the group and learn more about it and hopefully be able to contribute. So yeah, excited to work with everybody.
Wonderful. Thank you so much, Courtney, and thank you for stepping up and joining the group. I'm also going to take the opportunity now to say out loud again, I think I said it at the last meeting, that we are looking for to add to our primary care advisory group. So if folks, either as members or members of the public attending this meeting, if you know anyone who is a primary care clinician and is interested in contributing to this group, please send them our way. We would definitely love to broaden our reach. We're in particular looking for physician assistants. And we at this point, we don't have any PAs on the group. So if folks know anyone, please send them our way. I have reached out to the hospitals and to Health First for them to see if they had any additional providers as well. Okay, with that, I am going to go to our next agenda item, which is the GMCB and the Primary Care Advisory Group updates. I am going to turn it over to Julia, who's going to start with the Green Mountain Care Board updates. We have some exciting, I don't know if I want to call it exciting information on prior authorizations. They're not exciting, right, Julia? But it is, Julia has some expertise in this area, which she might share a little more background that she's worked on in previous roles. So she's been very helpful to the board in some of our reporting and in some of the work that we're doing to address prior auth. So I'll turn it over to you, Julia.
Sure. Yeah, thank you for the introduction. I will see if I can be exciting or not. Yeah, so as Susan said, we wanted to give some updates on prior authorization. One, because we know that this is a very important issue to this group and that the PCAG has done a lot of work in providing information and areas for potential improvement related to prior authorization. And then also that there's been some activity in the month of January and since then, so wanted to make sure everyone was aware of it. And as Susan mentioned, I do have some background in this policy area. Prior to coming to the Green Mountain Care Board, I was working at a nonprofit patient advocacy group, and we spent a lot of time talking about prior authorization and the barriers, particularly through the patient lens, that it sometimes caused for folks accessing the care that they needed. But additionally, through that work, I spent a lot of time collaborating with provider organizations and spent many hours on the phone hearing from providers about their experiences. So I imagine it is many similarities to what this group has discussed over the years. And additionally, I helped last year with the Act 140 report that the board did, and I saw in there the history that PCAG has done in putting together some principles around prior authorization. So with all of that in mind, I had a couple updates to share with you. So the first is that the board, along with a couple of legislative committees outlined in the bill, have received reports from insurers about their gold carding pilot programs. Those came in January, and I believe they were also shared in the email that went out to the group ahead of this call. So the reports have updates about how those pilot programs are working, and they're also on the board's legislative reports page of our website. So encourage you to check those out. And additionally, GMCB also collaborated with the Department of Financial Regulation on a report about opportunities for further reporting, as well as policy options that the legislature could consider to streamline prior authorizations. And that report is being submitted sometime this week. So we will, once it's officially out in the world, we're happy to send a link to the group. And finally, I'm guessing folks on this call are aware of this, but we did want to also flag legislation that's been introduced in the House, H220, which includes both a section about primary care spend as well as prior authorization. And the prior authorization section, from my quick read, would essentially expand a gold carding-like program. So as of now, one, we internally at the board have not done a deep dive. And additionally, the committee has not had hearings on this bill yet, but I'm sure, like I said, that folks on this call might already be aware of it. But we would imagine that the committees will be reaching out for provider input. So we wanted to make sure that this was on your radar. So I think that's all that you wanted me to cover, Susan. So I'll pass it back to you, and you can let me know if it was exciting or not.
Very exciting. And I apologize for background noise. We had a garage door problem, and they're repairing it right now. So hopefully the dogs will settle down. Two things. Yes, that was very exciting, Julia. And I am just very excited to have you working with the board, because you have had experience working in DC for advocacy groups addressing prior auth. So that's really that talent that Julia brings to the table for us is really helpful. That's number one. Number two, I forgot to go around and have the members of the primary care advisory group introduce themselves. I also see some other names and faces for the public. Specifically, I see David Reynolds, who I haven't seen in ages. So maybe after the PCAG members introduce themselves, we can just call out folks who are also on the line as members of the public. So thank you, Julia. And sorry, I am not Christina. She ran a really tight ship and she wouldn't have forgotten this. Faye, I do see you have a question. Do you want to ask your question first? Does that work?
There's a power drill going on behind me, so I'll wait.
Okay. It's a lot of background noise here. So I'm just going to go around my screen and on my list and just call out the current primary care advisory group members. Courtney Ledger, we already heard from you, so thank you. And Elliot Rubin, Dr. Rubin.
Hello. So I am a retired primary care pediatrician after being in practice for 36 years, and I'm living in Plymouth, Vermont.
Thank you. And Eileen Murphy.
I'm a family nurse practitioner, mostly rural Vermont and almost all Orange County.
Wonderful. And Tim Tanner, Dr. Tanner.
Hi, I'm Tim Tanner. I'm a primary care clinician, internal medicine, pediatric boarded. Work at the Danville Health Center, was hired by David Reynolds in 1993. And I'm also the medical director for Northern Counties Healthcare at the FQHC based out of St. Jay.
Great, thank you. And I see Michelle Wade.
Good evening. I'm Michelle Wade. I'm an adult geriatric primary care and acute care certified nurse practitioner, and I live in Rutland County, and immediate past president of the Vermont Nurse Practitioners Association.
Thank you, Michelle. And Valerie Rooney, Dr. Rooney.
Yeah, hi, I'm Valerie Rooney. I'm a pediatrician who practiced in Windham County for 30 years, and I now primarily teach at Dartmouth at their Geisel Medical School. And I live next door to Susan in the Small World department.
Very small world. Love my neighbors. And Lee Lepresti. Oops, you're on mute, Lee.
You probably didn't want to hear any power drills behind me. So I'm Lee Lepresti. I'm a family physician and currently living in Danby, and not much more to say.
Thank you. Thank you. Faye, do you want me to still wait, or?
I think we have a little breather here.
Okay.
So Faye Homan, family physician at Little Rivers Healthcare in Wells River, approaching my 30th year in practice here. And yeah, that's all.
Great. Thank you. And Katie Marvin, Dr. Marvin.
Hi, Katie Marvin. I live in Hyde Park and work at Lamoille Health Partners in Morrisville and Stowe, and oversee family medicine there, and the immediate past president of the Vermont Academy of Family Physicians.
Wonderful. Did I miss any other PCAG members? I'm looking on my list and my screen. Please shout out if I did.
This is Rob Penny.
Rob, thank you. Thank you, Dr. Penny. I thought I saw Alan Ramsey. I did. Alan.
Yeah. Hello, everybody. My name is Alan Ramsey. I'm currently the medical director of the People's Health and Wellness Free Clinic in Barre, Vermont, not too far from you all, and was an original member of the Green Mountain Care Board, the first from 2011 to 2016. And then I was the chair of the Green Mountain Care Board Nominating Committee from 2016 to 2019. So I'm free and clear.
Don't you seem so excited about that? Okay, I think I got everyone, but speak up if I did not. I do want to call out, I see on the list a couple of folks who work for our federal delegation. First, I see Ina Backus, who is newly working for Senator Welch. Welcome, Ina. It's great to have you here. And I believe I saw, and Wally too. Hi, Wally. I believe I saw Beth Stern, who is part of Senator Sanders' staff. So thank you both for being here. We really appreciate you taking time to listen in tonight and chime in as we go through the meeting as you'd like. I know we have public, we will have an opportunity for public comment at the end. And I do just also want to recognize Stephanie Winters, who is with Vermont Medical Society, who we work very closely with, and is often here to add in some of on legislative issues and others, some of the provider perspective. So with David Reynolds. Oh my gosh, are you with Senator Sanders too?
I
see
am.
help. Oh my God, I'm so sorry. Well, I mean, not about
What do you mean you're sorry?
I'm so sorry I missed you. Do not let Senator Sanders know I said that, please. David, please introduce yourself, because I think folks would love to meet you.
Well, I see a lot of old friends here. And hi, Faye. And Grace. Hi, Grace. And of course, Tim. Well, I was happily retired until 3 weeks ago. And then I had worked for Bernie as his senior health policy advisor when he first got elected to the Senate. And we worked hard on the Affordable Care Act. And he's now chair of the Health Committee, as you know. And a major effort that he's going to be involved with this year, his major legislative initiatives are primary care and healthcare workforce. And so he resurrected my name, I guess, and called me up and asked if I would come and help on those two ventures. And so I have agreed to do that for a period of time, not permanently, I hope, but it's a great opportunity and a great crisis we're facing in those regards. So it's so I'm commuting back and forth to Vermont. I'm on like the senator schedule. I'm here 4 days a week. So, and then I come home. So, but it's great. I'm very anxious to hear what you guys are up to.
Yeah, you will. Tonight is a great meeting to listen in on, and I'll just say this primary care advisory group has helped the board and informed them on many of our activities, and they are a real resource for us, and I'm sure will be a resource for you, David and Beth for Senator Sanders and Ina for Senator Welch. So welcome everyone. I will turn this back to the meeting. We shared our Green Mountain Care Board updates. I do want to open this up for any of the primary care advisory group members to share any updates here and now. We also have another discussion time after the presentation. So happy to hear from all of you at this point. So I will open up the floor. Any updates from the primary care advisory group members? Or Stephanie, if you have anything you want to add from VMS. Oh, there's Faye. Go ahead, Faye.
I just I wondered if we could go back for 1 second to the gold card report, which I looked at, and I have to say it was 13 pages long, and it had a lot of sort of what sounded like state government language in it. And I was looking for the beef. I was looking for the data. Are the programs working? And I may have lost patience early with it, but I wonder if anyone could summarize what the outcomes were on that.
Julia, do you feel prepared to do that? If not, we can get back to them.
Yeah, I think it would be good to, in part, get back, but at a high level, there were 4 gold carding reports. So I guess first, I just wanted to make sure, and Faye, happy to send you an email, that you were on the right ones, because there's 4 different documents from the 4 different carriers that submitted reports. 3 of the 4 did say that they plan to continue the program, so I think that is a highlight to share. Additionally, part of the reporting included getting feedback from providers, and there was some information sort of about the limitations of the carrier's ability to do that in the short time frame, and given the fact that they were implementing these programs also during the pandemic. So I think the results are still out, was somewhat my takeaway, but that the fact that 3 of the 4 said they plan to continue the program, I think was an important takeaway. But beyond that, I don't want to sort of speak for them beyond what's in the report.
Thank you, Julia. And I did not say earlier when we talked about, I was going to add when Julia introduced the prior auth activities, the gold carding work is something that the board has taken a position on in the past of supporting. And we, as Julia mentioned, we just released submitted a report today with DFR and recommended that continued work on gold carding. But Faye, I appreciate your comments, and I know there are carriers on the line listening to us right now, so I think that for them to hear that as well is helpful. Dr. Tanner, and actually I think Alan Ramsey might have been first. I'm sorry. I don't have numbers next to your raised hands, but I think he was first. So Alan Ramsey, Dr. Ramsey first.
Yeah, I would just offer to connect with you, Julia, about a study that we did while I was on the Green Mountain Care Board with Medicaid, Blue Cross Blue Shield, and MVP, studying whether eliminating primary care prior authorization for certain drugs and for a commonly ordered MRI scan raised the cost of care in any measurable way, and it did not. And this was a controlled trial that we completed, much to the chagrin of the commercial insurers and Medicaid, but we were able to prove that specifically with primary care, we could eliminate prior authorization without adding to the total cost of care. So I'd be happy to connect with you at some point about that.
Thank you, Dr.
Yeah, I
Ramsey.
would definitely welcome that. And Susan, I would also just add, I am definitely not prepared to summarize the numbers, but part of the gold carding reporting also included asking the carriers to give a request of the cost of the program and the ROI. So again, it's different by each carrier, but we can resend to make sure people find the right spots. I think that's an interesting piece of the study.
Thank you. And now, Tim Tanner, Dr. Tanner.
Yeah, I guess sort of a fire from the hip response after reading the reports, as I was pretty underwhelmed. Struck by the lack, well, I don't know if there's any way to easily measure the cost to providers, but it seemed like a really siloed report from the perspective of the insurance carriers only. So it's lacking the, when they're looking at their costs and ROIs, not sure if that included the cost of staff in primary care offices that are, taking the time to do the prior auths. So that seemed to be missing. And the other, I get it that prior auths are not going to go away. They're the only tool that insurers have to try to control cost. And the numbers of, it seemed like the number of people, of providers that were gold carded was so small, and the numbers of prior auths that each of them had was so small that gold carding doesn't seem to me like it's going to make a difference. It's just too small a number in any one practice to really reduce the prior auth work. So then, those are just comments. I also do wonder if there's a way now with even more big data and claims data particularly for drugs, if the insurers could use drug history and have some kind of smart technology to look back and see all the drugs that have been used. That's one of the big deniers for or prior auth for meds sometimes is you have to use this drug or this drug first. And oftentimes, at least for me, I've already done that. And still we have to go through the prior auth process and show that, that one of the nurses got to submit all the tried and failed drugs. So isn't that data available already in drug history, maybe through Vital or some other claims base to eliminate, at least for drugs, some of the prior auths? Just some comments.
Thank you for all those comments. And again, I know there are some members of, I know Blue Cross Blue Shield here tonight, so I know they are listening in on this. And thank you. I think that's really good feedback. Any other? Oh, I see Stephanie Winters has her hands up. Go ahead, Stephanie.
Thanks, Susan. I just wanted to respond to Tim that totally understand that. We've been testifying about how small these groups are for these gold carding pilots. The bill at hand would actually be if you've been approved 90% or more, which would be almost everybody for any healthcare services, you would not have to go through the prior auth process. So this would be a good bill to get behind. And Alyssa Black, Representative Black, who is on the House, the vice chair of the House Healthcare Committee, and also a practice manager, a billing manager at Evergreen Family Health, submitted this bill. And so I think we could possibly get some traction using some of the report data and also looking at the costs to practices, because I think that's where the rubber meets the road. And everyone talks about how they want to support primary care. This is a good way to do it for administrative burden. I also just wanted to, if I can, Susan, since you did ask, I just want to say a couple things about other areas that would provide support to primary care. So there's a proposal to expand Blueprint, to put a lot of money into the Blueprint to expand community health team supports for primary care practices. I think it would be almost $6 million to go into that to provide support and increase the per member per month payment for community health teams by $4.68. I think I just saw it today, so don't quote me on that number exactly, but I think that would be a really big support. And so that and a program to do more on substance use disorder and more with the hub and spoke. So that's one thing. And the other is that VMS in particular is pushing for Medicaid to raise payment rates, at least for an inflationary rate, because it's level funded in the governor's budget. So if you recall, in 2022, we got the rates raised to 2022 Medicare rates. And then this year they're level funded. And so trying to get that into the DEVA budget. So just a couple things to look for in terms of practice sustainability and financing.
And Stephanie, if folks from the PCAG wanted to testify, I'm sure like through your channels, this is where it gets a little bit, there's members of the PCAG who are also members of VMS and the advocacy work. I think VMS and the Green Mountain Care Board have worked really well over the years to make sure that you all are aware of advocacy opportunities, and depending on what the issue is and what you're testifying on, I think all of you would be able to go as if you were a VMS member and a PCAG member. And we will definitely keep our ears open and talk with any of those legislators to see if there are opportunities for them to hear from you. I know we were in testifying, Chair Foster was in testifying in Senate Health and Welfare, and one of the senators expressed a desire to make sure that they hear more from PCAG members. I guess you're very well known over there. So I will work obviously with Stephanie if those opportunities come up. So I wanted to just mention that as well. Dr. Penny, you have your hand up.
Okay. Yes. Regarding getting back to the prior authorizations issue, it's unfortunate this study didn't include medications, which I think is probably a bigger headache than the imaging prior authorizations. But that aside, with regard to imaging, I would like to see the insurers and Medicaid or any of the payers provide some information on imaging studies that are rejected, and then some weeks or months down the road, does the patient in question end up getting their imaging study? Because, and I suspect a lot of them do, in which case it's rather pointless to reject those prior authorizations. That wasn't mandated, I guess, as part of the pilot program, but I think that would be very interesting data that I would like to see from the payers.
Thank you. Thank you, Dr. Penny.
Susan, I was going to just jump in quick and flag that the MVP pilot program did have a limited pharmacy component as well. If folks have a hard time finding that, I'm happy to help, but just wanted to flag that.
And we hear that a lot, Dr. Penny, about what you all are facing. I mean, you're facing a lot of issues around prior auths, but the drugs are enormous. And so, again, good to have folks on the line listening, whether they're with our federal delegation or at insurance companies, and of course, board members to hear that as well. Anything else? Any other comments or updates from PCAG members? Okay, great. I'm looking at the time and I do want to stay on time here at 5:40. We're going to turn it over to Blue Cross Blue Shield. But there is going to be an opportunity for public comment. And I do see a lot of folks who are here listening in, and I just want to make sure that you have an opportunity to comment as well. So we will move to the next agenda item, which is the presentation from Blue Cross Blue Shield on their Vermont Blue Integrated Care Program. And would I turn it over to you, Grace, or who would? Yes. Okay. So I'm going to turn this over if you to Grace Gilbert Davis. If you wouldn't mind introducing yourself, Grace, and anyone else who's presenting with you. And I know you have slides, so we can help you share those too if you'd like.
Thank you, Susan. Yeah, well, the slides are being brought up. I'm Grace Gilbert Davis. I'm the Corporate Director for Healthcare Reform and Quality Improvement for Blue Cross Blue Shield, but I have a long history of working on the provider side. So many familiar faces here, and so glad to see David Reynolds, who probably is the most successful failure at retiring that I know. So we have a lot of material to cover, and rather than do introductions, which could be rather lengthy, we'll go through the agenda. If we can move on to the next slide, please, Rebecca. We do have subject matter experts who are with us today, some who are not, but their names and contact information, titles are on the next slide. We're going to quickly go through sort of our value-based care framework, what we call the Reform Innovation Lab, and then we're going to talk about VBIC, which is the program that we are so excited about. And then we're looking forward to not only your questions and answers, but also your feedback as well. Next slide, please. So again, subject matter experts, contact information, title, feel free to reach out to folks. And some of these individuals will be presenting this evening. They'll introduce themselves at that time. So the framework for VBIC, Blue Cross Blue Shield has been involved in value-based pilots, learning collaboratives, and programs for many years. It really came into our own along with Brattleboro Retreat when we formed Vermont Collaborative Care, which is a payer-provider partnership with a focus on MHSUD value-based care initiatives. Blue Cross, since 2013, has focused primarily on medical primary and specialty care initiatives. There is a number of examples of some of the pilots that we're not discussing tonight in the appendix. And if anybody wants further information on that, you can feel free to reach out to myself or Dr. Tom Weigel, who I terribly forgot to put him on the slide with the subject matter experts, but Tom Weigel is our Chief Medical Officer, and he is the Senior Executive Sponsor of VBIC, and he is with us this evening. So next slide, please. So the Innovation Lab, formerly the Reform Innovation Lab, now the Value-Based Care Innovation Lab, is a multidisciplinary work group that came together because we had all of these value-based care initiatives going on across the organization. And we wanted to make sure that we captured them, not only captured them, but that we had a way to formally assess new ideas like VBIC as they were evolving, help operationalize new initiatives, definitely implement an annual auditing program to look at these initiatives. So instead of they just sort of petering out, we want to determine based on the goals that are established within these pilots, are they worth continuing? Should they continue as a pilot to continue to gather data? Are they successful enough that we want to move them into the program status? Or, good try, but not worth further investment and sunset them. We also serve as a research hub. We're always combing through the literature, looking for other ideas for advanced primary care models. And then, of course, the Innovation Lab aligns with Vermont Collaborative Care as well. Next slide, please. Next slide, please. So, Vermont Blue Integrated Care, or VBIC as we refer to it, is the largest pilot in Blue Cross history with over 10,600 attributed lives. And I want to do a shout out to the participating practices, Evergreen Family Practice, who is absolutely instrumental in helping with the initial development of VBIC. And then the other practices that join who have continued to help us fine tune it, Thomas Chittenden, Little Rivers Healthcare, Federally Qualified Health Center in Orange County, and White River Family Practice in Windsor. Again, all of these wonderful practices to work with. We do have a waiting list of folks who are interested in VBIC, but this pilot with these 4 practices and these 10,000 plus members will run through 2023. We do not want to repeat any mistakes that we have seen both in our state and in other states where you implement a program like this, VBIC, and you continue with it regardless of whether or not you think it's succeeding. We want to formally evaluate it throughout 2023, the pilot period, and only if we've determined through working with the practices and our own internal assessment, we will only expand if we've determined that it works. Right? Next slide, please. The design is simple, really simple, and it's based on the Institute for Healthcare Improvements, quadruple aim. So, patient experience, population health services, reducing costs, obviously, and the 4th, which was added not so long ago, and that's the care and well-being of the clinical teams that we work with. So I will say that in addition to looking at this from a value perspective, an outcomes perspective, the experience, co-developing it with primary care practices, that this is intentional. This is an intentional model that we plan to, with the practices, develop a hybrid value-based care reimbursement model that we will transition to in an agreed upon timeframe together. Next slide, please. The design elements, again, fairly simple. We're going to run through them: disease management, care coordination, and transformation of care. Next slide, please. Disease management. So our focus in 2023, 2 quality metrics, 2. One is patients with type 2 diabetes and those patients with uncontrolled hypertension. For the diabetic patients, this is an idea that we actually co-opted from Evergreen Family Practice, so I have to give them credit for this. We are providing at no cost to the eligible members continuous glucose monitors. And again, this is for patients with type 2 diabetes. It's not typically a covered service or a covered expense by Blue Cross, but we wanted to understand, along with Evergreen and the other practices, if these patients used the monitors for 180 days, would they understand better how to manage their condition? And so the goal for year 1 is reduce the patient population. So each practice is identifying eligible patients who are getting the CGMs. And the goal for year 1 is to reduce the patient population's A1C score by 1 point. And then obviously over time is to reduce the total cost of care for diabetes treatment. Next slide, please. Similarly, with uncontrolled hypertension, we're providing at 0 cost to the eligible members identified by the participating practices a pressure cuff, blood pressure cuff. And again, for year 1, we're only looking for reporting only, and we're hoping that with the patient cohorts in each of the practices, we're just going to see sustained improvement in the patient's blood pressure reading. So 2 simple quality metrics that we are focusing on in year 1. Next slide, please. The next element is care coordination, and this is a 2-parter. So I'm going to turn it over to Julie Zach, our Director of Integrated Health, to explain collaborative case management services. Julie?
Hi, everyone. I'll start with this slide to just give an overview of the services that we have at Blue Cross for collaborative case management. So what I try to do is set the different services we offer against kind of a continuum of the population. And you can see that a lot of the services are geared more towards folks that are managing illness or are complex, which is aligned with where case management tends to be most. We have transitions of care, which is follow up with folks who are leaving inpatient care or stepping down from some higher level of care. Case and disease management, which focuses on folks who have chronic conditions, often multi-chronic conditions or other high health complexity. Blue Cross Specialty Health Support is a program that we have for folks who have less common but also complex and chronic conditions, where we actually partner with another organization that helps bring a level of specialty care to those folks. So this would be folks who have things like ALS, ulcerative colitis, multiple sclerosis, things like that, where they can get some of that specialized expertise from the case management team that will then work with their different providers as well. We do care coordination, and just in terms of trying to help people connect the dots across the system, and often work there is related to helping to align the treatment plan with the benefits. So things like making sure folks are getting the DME equipment that they need, medications that are aligned with their benefits and things like that. And then in that also, we do follow up with folks coming out of the ER where we can and make sure that they have the right follow-up appointments, if there's anything else they need, see if they need to be connected to a primary care provider, which we often find and help them with. And then there's our Better Beginnings program, which is our maternal wellness program, and that is a program that is universal. We work with all levels of pregnancy risk, and it's for any pregnant member, and we toggle our services depending on, what that person needs and what their pregnancy risk is. So this just kind of gives you an overview of the type of programs that we provide in case management. Next slide. So this is starting to think about what are we doing in terms of working with the VBIC practices. And over the course of 2022, the main goal was just really to orient practices to our approach to case management, health plan case management. I used to work more on the provider side, but as I've worked with the health plan, it's just not something that's often very well understood. So there's just a piece of helping folks understand the services we offer at baseline. And then also starting to provide them with reports of their practice-specific data on their patients that have been in case management with us or are in case management with us, so just to get a sense of that. And eventually we'd like to combine that. So depending on the resources that they might have in their practices, how do we look in a combined way so that we're complementing each other, not duplicating efforts, and really start to be looking at that together. And the graphic on the right just gives a sense of the types of data that we're sometimes looking at in terms of, this is sample illustrative data, but you can look at the overall identified population of folks that we've identified for case management, and then what has happened in our efforts with them. The portion that are engaged, people who might be unreachable or declined, folks we're still trying to reach, and be able to look at that together with the folks in. And then on the next slide, I just wanted to share, how I think we're thinking about just creating that momentum and capacity to do that collaborative work together. So in 2023, just starting with, putting the building blocks that will help to create that foundation, and looking at some meetings with the case management, care coordination leadership across the cohort, so we can understand the different resources that we each have and figure out, how things might work effectively and efficiently for everybody. Start using the data that we have for decision making and action, and taking a look at it together, orienting people to that and how you think about and use data together.
Julie, have we lost you?
Can you guys still hear me?
Now we can.
Now we can.
Oh, that was strange. I got a message that I was muted. I'm using the phone, but I'll keep going.
Yes.
And then in 2024, moving ahead with looking at some shared metrics across the practices, thinking about learning and quality improvement and places we can do some of that together. We have our accreditation requirements. Practices look at how they can be patient-centered medical homes, and there are places where I think we can improve different, we have the same aims, the same quality improvement goals, and you could work on that together. And then really getting to how do we communicate about specific patients and address their needs together and do that clinical collaboration. And I'm going to turn it over to Charlie.
Good evening, everyone. My name's Charlie, and I manage our risk adjustment programs. And I'll go quickly, but as Grace had mentioned earlier, my contact information is available for further individual questions, overall comments, whatever you prefer. What we're doing here in the risk adjustment side in supporting panel management is that overall, we're supporting our providers and their office staffs so that they can better serve their patients. And one of the ways we do that is with our PSP program, our practice-specific partnership program. And this is just what you see on the left side, or left 2/3 of the slide, is just an overview of one of the things that we offer in that high-level Excel package and reporting package we release to providers and their practices on a quarterly basis. And this example is showing, data through the end of September 2022 for the members that selected a provider in their practice as their PCP. And then we split this between chronic members and non-chronic members. Now, you can see some of these categories are highlighted with a color, we provide a separate tab in the Excel document of all of the specific detail of the members, their providers, conditions, etc., on that information. So in this example, we have 500 members with 150 having a chronic condition. What we're focused on and trying to support those providers with is their more frail members and how we can support them. So now we're looking at those 150 members and how many of those on the left side have not had a visit with their PCP. Remember, these are members who chose a selected PCP versus those who, have had a member, a visit. And then from there, we're looking at, okay, those who had a visit, did all their chronic conditions get closed, or are they, one or more still open? On the right side of that graphic, you see, okay, they had a visit. Many of those have been closed. 45 of those 80 members had their conditions closed, but 35 still have one or more chronic conditions open. And then at the very bottom of this, we're trying to create, I need to let you know, when I first developed this, it was a data dump. And people said, hey, Bozo, what's your problem? We don't know what to do with this. And so we created what we thought would be helpful and what we understand now from the practices as we work with them to say, hey, what's actionable? And so we've developed something and identified, hey, you really need to try to get these 27 people in based on the data we have in the last quarter. 17 of these people have 3 or more chronic conditions that are still open. And, you have a half a dozen of these who have 5 or more chronic conditions. Trying to let the provider know and the office staff who they need to see and try to schedule. And by the way, you got a lot of other individuals, 2 chronic conditions, they're high risk. And we offer, the benefit is we're telling the provider, you're the PCP. Here's the last time a member has been seen. Here are their, suspected chronic conditions. The benefit to the patient is we're trying to support you as a provider to ensure that the member, your patient, is following through on their prescribed treatment program and plan. And then, overall, working with the practice, we're identifying, and we offer additional services, not necessarily highlighted in this graphic, of what are you doing on your documentation and improvement, and where can we tell you what you've done well on documentation and coding? Where are there opportunities for improvement? Are there education and training opportunities and things of that nature? A lot of this we do through remote access. And so with our VBIC partners and many of the largest provider groups in our network, we have remote EMR access, and we can support the practices, the facilities, the individual providers on what they've already had in their medical record documentation versus what's submitted on a claim. And I will tell you what I tell my team, providers submit a claim to get paid. They do not submit a claim to tell me the clinical picture of the member. And so based on that, the doctor, the provider may have already done all the work. We just don't know it by looking at claims. So we're trying to work together. Next slide, please. Folks, if there are questions, please don't hesitate to ask.
I do see there were a couple of questions, and I was going to ask Grace, do you want us to wait until the end of the presentation, or it sounds like you're open to them?
I'm open. Let's go.
I know there was one in the chat from Dave
It's
Merman.
Dave Merman, actually.
Yeah.
So I'm not familiar with the closed and open terminology. Emergency person, so maybe it's different than what we we do an emergency, but what does that exactly mean?
All right. I'm going to use my name is Charlie. And if we have a Dr. Booten in our network, I apologize because you're going to be the bad person. But Charlie presents himself. We suspect Charlie has diabetes, CHF, COPD. We have information, claims that have come in that closed Charlie's diabetes and CHF. We don't have anything that tells us Charlie's COPD has been closed. Closed, open, your question. Closed meaning we suspect Charlie has these three conditions. We have a claim that gives us a diagnosis code that explains, yes, Charlie has diabetes, he has CHF. We don't have a diagnosis code that says Charlie has COPD. However, if we go into the medical record and we see, oh, hey, doc, you did address Charlie's COPD issues and said this is what's going on, we can then close that and not say that Charlie's COPD is still an open question. Is that helpful, or
Okay,
did I
so
convolute things?
yeah, so it means it's been addressed in whatever the time period is that you're measuring, like documented that it's been addressed. Okay, yep.
Right.
Thanks.
And the addressment period is a calendar year, because that's how we have to report back to the government. And I've got to think whether I want to use open and close versus addressed or not yet addressed. So thank you. I have to take that back. Next question.
I do see there's a question from a PCAG member, Lee Lopresti. Go ahead, Dr. Lopresti.
So I noticed there were layers and layers in several of these slides where, well, I'll pick out the one in the first one where 52% of the people had been contacted or were enrolled, or I forget what the terminology was. But I guess when
you want us to go back on slides?
No. This is
Okay.
52% of the people were actually sort of participating, if you will. My question is, when you do the analysis, are you going to do this on an intention to treat basis or on a protocol basis? I mean, you know, because if you do intention to treat, you've got 48% of the people who aren't actively being treated, and that's going to screw your numbers.
And I appreciate that. Go ahead. Somebody had a comment or question?
No, we're talking about Julie's collaborative case management program.
Yeah, I mean, I think I can just explain sort of what that we meant by sort of engagement rate. So when we talk about someone being engaged with case management, it means that they've had a conversation, interaction with one of our case management team members. And then that can range from something that's a very brief interaction and intervention that might be around helping them with, you know, one particular thing that they might need, and they're not really interested in continuing longer term, but they're now aware and connected with our services, and sometimes they'll call back and seek additional support. And it then can also range in folks who are working with us for, you know, over a 3 to 6 month period, occasionally longer, on a care plan that has specific goals and things that they're trying to achieve. So that's specific to the case management support. I'm not sure I'm totally answering your question.
No, not totally, because you're going to have some people who have, you know, declined services or whatever. Are they going to be included in that 1 point drop in the hemoglobin A1C? Because if they're not participating, not following up, you are either not going to have data, or you're not going to have, well, I would hope you'd still have improvement. You might not. And that's going to say, okay, well, now we only got a 0.7 improvement. Why did we get that? You know, is that good enough, or are we going to throw the program out? And I would hope you wouldn't throw the program out if it is done on an intention to treat basis.
So related but unrelated, where the practices are actually tracking the A1C levels for those patients that are using the CGMs. Those patients are not necessarily engaged in case management either in the practices or with Blue Cross, but we can easily track their A1C levels to determine whether or not we want to continue with the CGMs. Does that answer your question?
better. I think I must have been confusing two different programs.
All right.
The CG program
the only-
and the Engage program, I think I had put them both in the same box.
All right. And Doctor, what I'm seeing in our risk adjustment and what we're offering as a panel management opportunity, we're offering information on a quarterly basis. Maybe we need to do that more frequently and differently, but please let us know. I'm very thick-headed, but I'm willing to listen. What we need to do differently, but the idea here is we're trying to support the providers and allowing them to understand a little bit more of what is of their chronic or frail membership population, their patient population, what is not yet assessed by what we see, and that is generally through claims. And with my team having remote EMR access, we can go in and see, oh, this has been done, but not necessarily submitted through claims. So that's an approach. If there is more that needs to be done, we need to have that conversation. I cannot tell you we're going to give you what you need, but we can at least listen and see where the opportunity is if that's there. But overall, what we are trying to do on our panel management opportunities is to give the providers, because if I come to you and say, hey, what about that Charlie character? And you say, oh, he's one of my sickest members. When's the last time you saw him? Oh, I don't know. And this is where we're trying to support providers and their office staff and letting them know, hey, the last time you saw this, more frail individual of your patient population has been, 12, 18, 16 months ago. Oh, we got to get that person in. That type of thing. So we really are trying to support providers. Go ahead. I'm sorry, I'm taking too long. Go ahead.
You're taking too long. That's okay. Let's go back one slide very quickly. Just to let folks know that one of the tools that Charlie's team is going to be using with the VBIC practices is it's an overlay, an EHR overlay provided by Innovacor. It's called InNote. It's something that we're going to cover the cost of, and it's going to help Charlie help the providers to reduce gaps in care and improve care. Next slide, please.
Thank you.
Thank you, Charlie. So very quickly, we've gone over disease management, which included 2 quality metrics and care management, case management, and then Charlie's work with risk adjustment and panel management. And now we're moving on to what we call transformation of care. And there are 3 components to this. There's the fit testing, there is the What Matters Index, and then the collaborative care management model. I'm going to turn it over to Barbara to introduce herself and to tell us a little bit about FIT.
All right, thanks, Grace. Barbara Casterline. I am the accreditation program manager at Blue Cross. And as Grace mentioned, the fecal immunochemical test is part of
Barbara.
a component of, yep.
Could you move in closer to your mic?
Yes, I will remove my video. There we go.
Thank you.
Is that better?
Perfect.
All right. So this is was a standalone pilot in 2021 using 3 practices. And of the 3 practices, there were 503 eligible members, and we had 72 tests returned. Our goal was a 10% return rate, which we were really ecstatic about exceeding our goal with the 14%. And there were 3 positive tests. So let's see here. So we wanted to include this in VBIC and take it off of a standalone pilot, include it in one of the components of the VBIC that we are doing this year. And of note, we wanted to say that the FIT, we wanted to make sure that these are members with no personal or family history of colorectal cancer. They go by our quality HEDIS metrics and guidelines. And then for year 1, including this FIT model within VBIC, the threshold is reporting only. So our goal this year is to have 18% of our total screens completed for our eligible population. And Kristen is going to talk about.
Go ahead, Barbara.
No, Kristen is going to talk about the What Matters Index, which is also another component of the transformation of care.
Thanks, Barbara. My name is Kristen Fletcher. I apologize, I'm not on video. I was having a little trouble with my microphone, so called in instead. Yeah, I am going to talk a little bit about the What Matters Index and give you a little bit of background on it. It is a validated health confidence tool that was developed by Dr. John Wasson. For those not familiar with Dr. Wasson's work, he's a professor emeritus at Dartmouth Medical School and spent 4 decades as a practicing internist and geriatrician. Through that work, he developed an area of expertise of assessing and responding to what matters to patients and reducing healthcare waste and inefficiencies. If you look at the questions on the left, they assess how confident patients are in managing their own health. Research on the WMI shows that low confidence correlates with the need for more costly services. So really what Dr. Wasson developed was an improvement on conventional risk models that identifies patient needs at the point of care and allows those needs to be addressed in real time. We included the WMI in VBIC to encourage the use of this health confidence tool in primary care practices, especially with those patients who have recently been discharged from an inpatient stay or have chronic conditions. There's an opportunity there to look at some of their needs specific to that population in order to create the interventions that could help them avoid costly care down the road. Next slide, please. And I'm also going to be talking about the collaborative care management model. This model specifically is referring to a model within the primary care office that consists of a primary care physician, a care manager who works in collaboration, and a care manager who works in collaboration with a psychiatric consultant. The psychiatric consultant provides regular consultations to the primary care team to review the clinical status and care of patients and make recommendations. So in looking at the research, in more than 80 randomized controlled clinical studies, COCM has been shown to lead to better patient outcomes, an increase in patient and provider satisfaction, improved patient functioning, and a reduction in healthcare costs. There are codes specifically for COCM that are reimbursed by CMS and Blue Cross. We included this model in VBIC to provide education about the availability of the billing codes and also to increase access to psychiatric care in the state. We also looked at some of the work that's been done by Blue Cross and Blue Shield of Michigan. They're ahead of us in sort of encouraging the use of this. And as of last September, they had 213 of their practices located in 33 counties around the state that were using the collaborative care model. And next slide, please. I think that's it for me, unless there are any questions.
Thanks, Kristen. So we're almost ready to wrap up. And I know this might feel complicated, folks, but it really isn't when you think about the fact that the program VBIC is 3 components, right? It's disease management, it's transformation of care, and disease management, transformation of care, and reducing gaps in care. So the payment model, for year 1, 2023, there's a maximum PMPM of $8. This covers population health management and the quality measures that we discussed earlier for diabetes and for hypertension. But also, if you noticed, as we went through the components, the elements of the program, there are goals established for each of them. Some of them are reporting only for year one. That's fine. We have to stand up the model in these practices before we can understand if they work. So no risk for year one, reporting only. Current fee schedule with capitation just for a defined subset of the members. And then our goal in year two, this assumes again that after assessing VBIC, it'll probably roughly be about 18 months for Evergreen Family Practice and 9-10 months for the other 3 practices who came on just a little bit later. We need to evaluate the program before we say for sure that we're going to expand. Should we expand? And preliminary data suggests that we will expand. We are going to work with the practices to develop, as I mentioned earlier, a hybrid value-based reimbursement model that will be a combination of PMPM tied to quality and total cost of care metrics, capitation, and frankly, there will remain some encounters that will be fee for service. We feel that this is the best way to begin the transition from primarily fee for service to full capitation. Next slide, please. Next slide, please. So this is I think one of the most exciting things when I was on the provider side working at the community health centers of Burlington and then Battenkill Valley Health Center, I would have loved to have gotten these reports. So every month we have an admin meeting with each of the practices. They receive a report, which we sent along to you, the members of PCAG, along with a slide deck to give you a sense of the richness of the report. It's long, right? There's a lot of information in it, but this first page shown here, this is the executive summary. This allows us to review practice-specific progress, right? For quality, care coordination, and total cost of care. During this meeting, after reviewing this information, we agree on, okay, what do we need to do for the next quarter to help us continue to progress, to improve in the agreed upon metrics. And then also to continue to fine tune VBIC as a program, right? Because it's a pilot, really it's a learning collaborative. We often refer to it as a learning collaborative because we're learning from the practices as we go along how to do this better. Next slide. There are quarterly provider meetings. This is where the providers from all of the participating practices come together with Dr. Weigel and members of the ops team, the Blue Cross VBIC ops team, to look at reports that include information on quality, total cost of care. The graphs that you see here are some of the examples that are in the report. Also, it's an opportunity to share best practices, right? How did Evergreen end up taking their entire cohort of patients with type 2 diabetes using the CGMs and have all of them realize a reduction of 2 points? Now, I'm just putting that out there as an example. It's also an opportunity for the providers to just share their experience in VBIC and to provide us with feedback. Again, we always want to fine tune this model to be the best that it can be. Next slide, please. Next slide, please. And so where do we go? So in 2023, we are meeting regularly with the practices. We're creating the practice-specific reports. We're sitting down and discussing those reports. Internally, it took a lot to stand up VBIC in Blue Cross. It's a multidisciplinary team that meets twice a week. There's a small group that meets on Tuesday, a larger group that meets on Thursday. So right now what we're working on is we've got it stood up, but how do we operate? How do we prepare it operationally to expand? We're always talking about how we can refine it. we're beginning to talk about what can we bring to the practices as a starting point to discuss a hybrid risk model, something to just work from. We have 2 quality metrics for disease management for 23. Obviously, we'll want to expand that, and I would hope that we would add a MHSUD metric in 24. So if after the practices complete their surveys and we've looked at the data, they've looked at the data, we decide this program works, we're gonna continue, we're gonna pilot again for another year, we're gonna add some additional practices. That leads us into 24. The original 4 practices, if all goes as planned, and there's been some bumps in the road, but if all goes as planned, the original cohort of practices, so Little Rivers, White River, Thomas Chittenden, and Evergreen, would begin to move into the hybrid risk model. The practices that are coming on board would enjoy the same experience the original 4 practices had in 23, and that is that there would be no risk. They would have the opportunity to stand up the VPIC program. And then, beyond that, right now we're working on a strategic plan for expansion and what will it take for us to expand it. And then looking at how do we work with the practices to establish that timeline, right? To move from primarily what is still fee-for-service to what we refer to as a hybrid risk model. I think that covers it. Let's go on to the next slide. Oh, back one, 2. So I'm going to just ask Dr. Weigel if he has anything he'd like to add or any comments that he'd like to share with the group. Tom?
Sure. Thank you, Grace, and thank you, everybody, for the presentation. And, I think we're really excited about this project. The 4 practices cover about 10% of our Blue Cross members. And there's quite a few primary care practices and actually specialty practices interested in both this project and other value-based projects. So this is a year where we're ramping this up, getting it going, seeing what's working and not working, and trying to at all times measure what we do. So I'm excited about this.
One thing I forgot to mention is that this was developed with intent, so practices can be part of OneCare or not. So Little Rivers, because they do not have a hospital in Vermont, their service area, they do not qualify to join OneCare. Regardless of whether you're in OneCare or not, you can be a member of VPIC. So we definitely build in as much flexibility as possible, because really this program, this pilot, is all about supporting the all-payer model. It's all about supporting reform in our state. And now I think we'll open it up to questions, and we would love feedback as well.
Sure. Thank you so much, Grace and Blue Cross Blue Shield Vermont team. I'll just say I'll open it up to the PCAG members. I think that's what it said on your slide, right, Lee? And also our board members, Dr. Merman and Chair Foster, if they had questions. And then we certainly will definitely have time for the public and others to ask questions after them. PCAG members? I see Dr. Marvin and Katie. Your screen is black for me. I don't know if it is for others, but go ahead.
I'm sorry, can you hear me okay?
We can hear you. Oh, there you are. You're there.
Hi, thank you for the presentation. I have kind of a more global question that maybe you can help explain. So I understand, well, I don't understand actually a lot of these ideas, but I do appreciate the help that we get from community health teams and all kinds of support. So I would support that no matter what. But I have a bigger question. Every time I hear the words quality measures, I kind of cringe because I feel like it really second guesses our judgment and skill. And it cares doing 50% of the visits on 6 to 9% of the overall medical income for the whole state, right?
Mm-hmm.
What kind of quality measures are you looking at specialty practices to make sure that they are meeting improving metrics, that they are evidence-based, that they are cutting costs, that they are not ordering unnecessary MRIs or doing unnecessary biopsies? I just want to make sure across the board that it's fair. You know, we are already spending less money and taking care of more people. And we know that specialty practices are, at least from my perspective, doing tests and studies and things that they probably don't need to do. And costing the state of Vermont, you know, that's where 94% of the income goes. So what kind of quality measures are you asking from those practices?
Grace,
So people have, wait, Tom, let me just throw this in. So people have heard me say this over and over again. I'm not sure why we're doing reform on the backs of primary care providers, because you do the most with the least. Right now, we don't have any specialty practices in VBIC. So I can't answer that question, but I know that Dr. Weigel can.
Sure, and this is the, unfortunately, the flip side of prior authorizations, and loops back to our discussion before. You know, prior authorizations are not just about, you know, kind of denying care. They're actually about making sure people get the right care at the right time, the right tests, you know, the right lab tests, the right scans, that somebody might get an X-ray instead of an MRI. So prior authorizations, you know, are one way that we do that with, you know, both primary care and specialty providers.
Dr. Marvin, are you all
Well, let
set?
me ask.
Oh,
let me ask a question. If we are to accept specialty practices, which I think is the direction of reform, which is where it should go, what type of quality metrics would you like to see for specialty practices, recognizing that, right, there's a span of different specialties and subspecialties? But is there one in particular that you would like us to keep in mind as we think about developing VBIC for specialists?
I think it depends on how much time you have.
Yeah. You can email
So
us.
in my inbox with 1,500 patients, I have probably 1,000 documents that have come to me from referrals and visits that my patients have gone to. And every day that I read them, there are tests, medications, studies, things that are done that are just not evidence-based. And I hate to say it, I really need my specialty peers, I really do. But patients prefer them when they don't need them, and there's really no barrier to making those referrals happen if the patient prefers it and doesn't understand that the care is providable at the primary care level. There are studies that are being requested that I can't get approved, but the specialist can, that I still don't think are necessarily necessary. If I can't get a MRI or a CT, I know the ER can. I know even if it's questionable. So I guess my point is that I see these referral notes come back to me every single day with, even if it's not about test studies and labs, just the visit itself is expensive and possibly not necessary. So I guess that's my question. Like, you were talking about cutting costs and we're looking at primary care, but I think we're the last place to look for cutting costs. We already are inexpensive. And it looks to me that the focus really needs to come onto our specialty peers. And I need them, like I said, I need them to be available when I need them to be available. But right now they're overloaded with a lot of primary care level patients and issues. It's a chicken and egg situation. We don't necessarily have the primary care providers to manage it. And that's probably one of the problems. It's the direction is going to specialty care because of capacity. So, you know, I've said before, it's not capacity, it's not capability, it's capacity at the primary care level, but we already know we're inexpensive. So I guess my push would be, let's make it fair across the board if we're going to be looking at quality measures.
Agreed.
Thank you, Katie, Dr. Marvin. I see the next person who had their hand up was Tim Tanner. Dr. Tanner?
Yeah, this is another metric concern or question. I mean, please don't add more. As an FQHC, we have the uniform data set. We have primary care medical home. We have one care. If they're more measured, please be sure they're aligned with what already exists.
Trust me, they will be. I remember the UDS measures.
Thank you, Tim. And Faye, you have your hand up.
Yes, thank you. I wanted to jump in to respond to Grace on what kind of quality measures we should have for specialists. And I think Katie was getting close to what I was going to say, but my answer would be, are they doing specialty level care? If they're doing primary care level care in the specialty clinics, that's an absurd use of our healthcare dollars. So we look at their notes and we see, is this specialty level care? Did they outline a treatment plan and send the patient back to primary care? Are they truly a consultant? We need our specialists to be consultative, send them back to primary care with a plan. And if not, there should be some sort of consequence for them.
Thank you, Faye.
Good feedback.
And Faye and Tim, you both have your hands up still. I don't know if that's legacy. I'm sure there's a way I could probably put them down. Okay, there we go. PCAG members, Chair Foster, Member Merman. Oh, I see Dr. Marvin has another comment.
Yeah, well, I guess it's just a follow-up. As Faye said, we've been saying this for years, and it's a shocking thing to me between the Green Mountain Care Board's mission to reduce costs and I would think an insurance company's mission to reduce expense, that it hasn't already happened. Like, I think there's like some explaining to do why the pressure has not been put on these unnecessary, expensive. I mean, I get bills myself just for things I had for my family, and it blows me out of the water. The expenses that I am paying myself for things that, in comparison, when I have a complex office visit for somebody with multiple problems, what I am able to charge. So, where PCAG, or where Green Mountain Care Board and where insurance companies have the ability to just stand by and watch these expenses still mystifies me.
Please rest assured, we are in active listening mode. And everything you're saying is noted.
Thank you, Katie. Anyone else? Eileen?
Can I ask a question, Dave Merman?
Oh yeah, go ahead, Dave.
Hey, so just a question on understanding where this sort of all fits in as a program. So this is the practices that are in this program are practices that have been in this program for a period of time, it sounds like, the 4 groups. Is that correct? Or is this, okay, and so this isn't intended to fill the sort of the Blue Cross Blue Shield one care split void. Is it or
No.
is that okay? All right.
No, this
is
separate. This is an advanced
okay.
primary care model. We started developing it in 2021 and worked throughout 2022 to further refine it. So no, it complements the ACO, can work with the ACO. It does not replace the ACO.
And are you all set, Dave?
Yeah.
Okay. Next is Eileen Murphy.
I had just put a question in the chat.
Okay.
But also just to support the previous comments. So well said. So just pretend I said the same things again.
Thank you, Eileen. Thank you, Katie. And now I need to look at my people and see who was next. Number 2 was Tim Tanner. Oh, actually, Alan, sorry. Alan Ramsey is next. Go ahead.
Yes, I'm here. So let me, Katie, I really respect your comments, and Faye, and let me give you a very specific example that might help Blue Cross Blue Shield. Many of my colleagues know that my signature work has been in palliative care and hospice end-of-life care. And over 8 years ago, the American Society of Clinical Oncology, ASCO, developed a quality measure that with certain parameters, a patient with extensive cancer should have a palliative care consult. That's an ASCO quality measure. Now, in my work, I'm still an associate. I'm an associate hospice medical director here in Chittenden County. I see patients every day who should have had a discussion about their goals of therapy long before they actually have that discussion. So that is a very specific example of where specialty care has failed a well-established ASCO quality measure. And I would guess that most of my primary care colleagues who take care of patients at the end of their life who have cancers that no longer are responding to many of the very effective and safe therapies, and then end up with a transition to quality of life care, as opposed to disease-directed care much later than they should have. And people are not happy with that. So that's a very specific quality measure that one of our specialty groups could achieve and haven't. And it has to do with where following the money and not addressing goals of care at the appropriate time in a patient's cancer experience.
Thank you, Dr. Ramsey. So I see Tim Tanner. Dr. Tanner's next in line.
Yeah, just wondering what risk look like when you say risk in year 2. What's that encompass?
Well, we don't know yet, but we do know that it can't be 100% risk. So it's going to have to be a combination of value-based payments that are tied to quality and total cost of care metrics. It's going to have some encounters that are capitated, and it's going to have some encounters that are still fee for service. It's going to be a hybrid model, and we don't know what it looks like yet. More to come.
Great. Thank you, Grace. Dave Merman, Dr. Merman, your hand is next.
Oh, I did want to sort of second a lot of Marvin's comments there too. I mean, as an emergency physician, I can tell you it's a lot easier to get an imaging study in the ED. And if I was wondering, thinking through a lot of this prior authorization stuff, and if you're trying to figure out, the value of the prior authorization programs, I think we should also look at, I think what Tim Tanner had mentioned in the chat earlier too, which is kind of unrelated but related to this, which is sending patients to the ED to get the imaging. It happens a lot, and there's a big desire to reduce unnecessary ED visits. And if you could make prior authorizations less onerous and getting CTs and MRIs less onerous, then patients probably wouldn't have to come to the ED for the CT or MRI. So it's just one other comment. I think there's a lot of value that's not captured in. Again, I'm sort of shifting to the prior authorization slide deck that was distributed, but that's not captured in the analysis of, okay, well, there's higher imaging among people who didn't have to go through prior authorizations. Well, I mean, we really, yeah, there might be higher imaging, but you may have avoided that imaging occurring elsewhere. Or as we recently, friends of mine at UVM recently discovered when they realized that their CT angio imaging had gone way up over the last couple of years. Well, their yield has stayed the same. So there's been a lot of deferred care. There's a lot of disease out there. So imaging is going up, but what's the yield of the imaging? It might actually be might be good. It might just be this weird last couple of years of healthcare.
This is Tom Weigel again. And just to clarify the gold carding, we looked at providers and quote gold carded for CT and MRI anybody who had a 5% or less denial rate. And we actually, for each provider specifically, over the 2 years, and because in part because of COVID, it was really actually hard to tell whose utilization went up or down, and we couldn't discern a real pattern in each provider. And so that's why we're continuing it, into next year to get more data. And Grace, that's actually something that we should look into, at least with the VBIC practices, and see if we can make sure those providers are on that list and look at, add that data to it.
One of the other things you might want to, sorry, I interrupted.
Please.
Advanced imaging that you order and the actual pathology that you find. I order very few CTs and MRIs, but when I do, I usually find something because I don't order that many. And so, you have to look at the necessity. And I've just seen so many cases where patients come to me. I work in Stowe, right? So I have all these athletes that want to ski like 80 days a year. And they come in because they have a boo-boo on their knee. And I tell them that they should go to PT and take it easy and stop trying to get to 100 days this winter. And then they go to someone else and get an MRI because they can get it from them. And I told them they didn't need it. And they get it. And it doesn't change anything. They still have to go to PT. They're not a surgical candidate. And I think that that's the thing, like look at the outcomes of that advanced imaging and if it actually changes the patient course or if it just increases expense. So, these are situations where we know primary care uses fewer resources. That's why, a couple meetings ago, I was suggesting that people should have to have a prior authorization. As much as we don't want more prior authorizations, but you should really have to prove that they need that level of care, but who knows? Anyway, that's too complicated. But point is, I think it should be based on necessity as well as how frequently it gets approved, because it's always going to get approved in the ER. They're always going to get a gold card.
Right. It's interesting you bring up the fact that you don't order a lot of expensive imaging. I mean, that is a criteria that we should also look at in addition to denials.
No, I mean, we are literally going to be implanting physical therapy in our primary care office because for me, it's the first stop. I do not order MRIs unless somebody fails physical therapy because it's evidence-based. Unless they have an absolute test that proves that they have a ligamentous injury, I don't order it. So even if they demand it, I'm like, nope, not going to happen. They can find somebody that will, though, and it's going to be more expensive, and it's not going to change the outcome in 90% of the cases.
Yeah.
Thank you. Thank you, Dr. Marvin. I see Chair Foster has his hand up, so go ahead.
Thank you, Susan. Thanks for the presentation. One question I had, the total cost of care targets, would those be negotiated with each practice separately? I assume they must be, right?
Yeah, I think initially they're benchmarking off of their own results for total cost of care. And then over time, we'll look at, do we want to establish benchmarks that each of the practices would want to strive for. But at the moment, they're benchmarking against their own outcomes.
And is that information shared with the different practices so that they know how the others are negotiating, what the others have done, or is it all going to be proprietary and individualized?
So I wish the gal who creates the data generates the data for the reports was here, but she had another obligation. So I have strongly suggested that we do create a report just like that, Chair Foster, for the quarterly provider meetings, because it's been my experience that providers are, in addition to being, very caring people, there's a level of competitiveness that is very healthy, right? Contributes to good patient care. And so not only do I think would it be helpful for the 4 practices to look at their outcomes, each of their outcomes. But again, going back to if Evergreen has an amazing, has reduced the cost of care for imaging to some unbelievable number, the other practices I would hope would want to understand how did Evergreen do that? Like what policy do they have in place? What systems and processes do they have in place? It's an opportunity to share best practices.
Okay, thank you. And thanks for the presentation.
You're welcome.
I think, Chair Foster, to answer your question directly, I actually don't know the rates and how they've been negotiated between the various practices. So I doubt that we would share the exact number of values with them. But I would hope that proportionately we would look for kind of equal amounts of savings. Initially, as Grace said, benchlining against each individual practice separately, and then eventually over time combined.
Thank you. And the Lepresti, Dr. Lepresti, see your hand up.
Oh, I'm off mute. Okay. I would. What was the thought now? Oh gosh. I guess my thought that I'm concerned about, along the lines of what Katie has already mentioned, is that we are already pretty low cost of care. So I don't know how much opportunity there is to reduce the cost even further. And if that is what we're being judged on, you're going to say, well, gee, you only knocked it down by $35. We're not giving you nothing. And that is going against, cost control. I mean, the cost control, as Katie said, I think a lot of it's on the specialty side. I mean, another example, see all the time are, people who had an MI 3 years ago, and the cardiologist says, yeah, you need to keep coming back every 6 months. For what? And the answer is, so I can see you and say, hey, you're doing great. And nothing ever happens in those visits, except they get an echocardiogram every 2 years just to make sure nothing's going wrong. And, it's that kind of thing that's where the money is. And who was it? Willie Sutton said that, he borrowed banks because that's where the money is. You guys need to go where the money is, and it's not with us.
So I'm just going to put out there something that we learned from Dr. Johnson, Mike Johnson at Evergreen Family Practice, when we were talking about, what happens when, and I'm going to use quality as an exact quality metric. What happens if you're in the 97th percentile for managing hypertension across your patient panel? And really, is there anywhere to go from there? That's a really high score. And Dr. Johnson said, you know what? It takes just as much time and effort to maintain a score of 97%. So getting there, right, that's important, but maintaining it is equally as important. And we took that to heart.
Thank you. And Tim Tanner, Dr. Tanner?
I just want to point out that there is I think, an unavoidable tension between some of the chronic disease management quality metrics and cost. To get someone's hemoglobin A1C down to target may involve using multiple medications, and you start adding on things that are more and more expensive. Or if you treat someone with guideline-directed therapy for heart failure, you end up with a lot more drug costs. And so to get those targets, for good outcome, for patient outcome, is going to probably cost more.
Agreed.
I don't disagree with that. And, one thing that we're actually starting to focus on is lifestyle medicine, and looking at training providers in lifestyle medicine, focusing on diet and exercise, and stress reduction and sleep. And so we are actually hiring a program director for lifestyle medicine who's working with providers throughout the state, mostly primary care providers. And we're working with the American College of Lifestyle Medicine to see about funding training for at least 2 providers at each of the 42 FQHCs throughout the state in lifestyle medicine to get them certified. And that's really how you reduce costs more for things like heart failure, diabetes, is focus on lifestyle and not the medications.
Okay, anything else from the PCAG or board members? If not, we can open it up to public comment for anyone else who's joining the meeting. Stephanie.
Thank you very much, Susan. Let me lower my hand before I forget. So I'm Stephanie Winters. I represent the Vermont Medical Society and also the Vermont Academy of Family Physicians in the American Academy of Pediatrics Vermont chapter. And I guess I have a comment, and then I have just a couple questions about the operational details. So the first comment is that as we talk about prior auths and administrative burden of our primary care practices, it gives me pause and gives me a little anxiety to think about yet another program that we're implementing that is duplicative of some of our other statewide programs, namely the Blueprint, OneCare, and the work that they're trying to do on a statewide basis through all insurers. So I worry about how that's going to fragment and add yet another layer of burden to our practices. It kind of reminds me of having multiple formularies or multiple prior auth forms. And so it gives me pause. I mean, it sounds like a great program. I just really do worry about that. You mentioned it's up to an $8 PMPM, and I'm wondering, so up to means that there's a range. What's the qualifications for figuring out that range, and is there a lowest number that you can't go below? So and then I have one more question.
Sure. So there, just your observation. We share your concerns, and in designing VBIC, again, we want this program to align with or collaborate with all of the existing programs and services in the state. We are not looking to duplicate. We are looking to provide an alternative, right? In terms of the PMPM, there's a $5 base PMPM. So if you're in VBIC and you're standing it up and you're identifying patients for the, what matters index and fit testing and the CGMs, you have a $5 PMPM. There's some variable in there. The what matters index, without going into a lot of detail, it sort of splintered off, and there is a 6-month parallel, separate but parallel learning collaborative that Dr. Wasson and Dr. Jill Bloomberg at Way River Family Practice, a VBIC participant, are working with the 4 VBIC practices on. And so there's a separate compensation for participating in that 6-month learning collaborative. So we backed out the $1 PMPM for the What Matters Index in VBIC. Once the practices are through with the learning collaborative with Dr. Wasson and Dr. Bloomberg and begin to use the What Matters Index through VBIC, then we reinstate the $1 PMPM.
Okay, thank you. And then you have 4 practices. So another quick, Dr. Merman mentioned about this being a backfill or a fill for the loss of revenue for primary care practices. with the Blue Cross and One Care withdrawal. You said that's not the case, that this was already happening, but I worry. So if there's 4 practices now, and I'm assuming maybe only 4 practices in the next year, like, are you going to expand how many practices can come in? I'm just worried about primary care practices and the loss of revenue. And so thinking of if this is a way to supplement some of that income, are you going to allow for more people to join?
Assuming that when we're done evaluating the program throughout 23 and in the first quarter of 24, assuming that we all agree, and all means the 4 practices and the VBIX team and Dr. Weigel, if we all agree that it makes sense to continue this pilot, then yes, we will accept additional practices. Would we accept all of the primary care practices in the state? Not initially. We're just not equipped. We're going to scale this up in a very thoughtful and organized fashion so that we don't repeat mistakes that have been made in the past, in our state and across the country with reform programs like this.
Are you all set, Stephanie?
Yes, thank you.
Thank you. And now, any other members of the public or any others on the line? Several folks joining us tonight. So if anyone has any comments or questions or comments for either Blue Cross or anything else we discussed tonight, I should open that up. Okay. So with that, I don't see any hands raised.
Can I just
Oh,
can I just say that there were in the chat
of
there
course.
was something earlier about the strong data supporting continuous glucose monitoring and decreasing overall costs. And I, from an observational level, second that as a very successful strategy. There's a lot of nods there too. So whatever we can do to get more continuous glucose monitoring out there is a huge benefit to society. I think. I don't know the cost data, but I bet you it's there.
Well, we'll know by the end of 23 whether or not this is something that we want to continue to cover for this particular patient population.
Yeah, I don't know the data, but I'm sure this is well studied throughout. I'm sure many of the primary care people here do.
The preliminary results that we're seeing are very encouraging. One of the practices, nearly the entire cohort, it's not a huge number of patients, but almost the entire cohort managed to reduce their A1C by at least 1 point. And the testimonials we're getting from those individuals using the CGMs is great. It's pretty heartwarming.
Dave, there's even evidence that using it short term can be useful, even if it's not for long term, even for 2 to 4 weeks.
Thanks.
Thank you. Well, thank you for the really robust conversation tonight. I want to thank Blue Cross Blue Shield Vermont for their presentation. I do not have the next date to give you for our primary care advisory group off the top of my head, but we will be compiling some notes. There were several things that came up in the discussion that we want to make sure, we'll have our minutes, but we're also going to be sending out a follow-up email to everybody with some of the things that were requested. And I do, just in closing, wanted to give a shout out to Ina Backus. I did this very quickly. As many of you know, she worked at the state for many years, and now, as she put in the chat, is working for Senator Welch's office as their state, as that office's state healthcare liaison. So we'll definitely send out her contact information. Also, Beth Stern from Senator Sanders' office, who had to leave early, and of course, David Reynolds, who I was really excited to see on the screen. So I had him introduce himself, but unfortunately didn't get to Ina and Beth, and they're both very valuable partners at the federal level. So thank you so much for coming this evening. Please reach out to either Jen or Kristen or myself if there are any other questions, but we'll put that packet out to all of you and with the date for the next PCAG meeting. Thank you for the discussion. And with that, we can close up for the evening. Thank you all.
Thanks, everyone.